Thanks for the opportunity to present today. I'm actually from Montreal, Canada, and today I'll talk to you about the inverse balance between the plasma levels of endocannabinoids, N-arachidonoylethanolamine and 2-arachidonoylglycerol, and their metabolites in people with HIV and subclinical coronary artery disease, based on the CHACS, or the Canadian HIV and Aging Study. First, I just want to take a brief moment to pay homage to Mr. Ron Rosenes. He was a community member who was living with HIV for 40 years or so and was a very active member of the community, was an Order of Canada recipient, a good colleague and friend, and he passed away unexpectedly on October 21st. But he's with us in memory. So as this group all knows, HIV is characterized by immune deficiency, and HIV is known to infect the gut CD4 cells, resulting in CD4 cell depletion, resulting in a leaky mucosal barrier, translocation of bacterial content, stimulation of immune cells, and it sets up this vicious cycle, making other immune cells more susceptible to HIV infection and so forth. This is blamed for this is thought to be the driver of chronic inflammatory diseases and atherosclerosis. So we know that cardiovascular comorbidities are common in HIV. Even in people without HIV, there's certain immune disturbances which are seen. When people with ART or when people with HIV are given ART, these are only partially normalized. And as many people presented today, we know that rates of MI and cardiac adverse effects are higher in people who have HIV, even with the heart therapy. So if we look now at the endocannabinoid system, so this is a neural hormonal system which exists throughout our body, and it's comprised of lipid signaling molecules composed of endocannabinoids, or molecules made by our body, CB1 and CB2 receptors, various enzymes which make and degrade signaling molecules. So CB1 receptors tend to predominate on the central nervous system, whereas CB2 receptors are very commonly found on immune cells, so T cells, B cells, monocytes, NK cells, and so forth. And this is important because this system is thought to play a role in virtually every process in the body to some degree: cognition, pain, memory, hunger, and so forth. And if we look at the cannabis plant, phytocannabinoids, the famous phytocannabinoids are THC and CBD. THC is an agonist at CB1 and CB2 receptors. CBD affects these very, very mildly, and it's thought to play a more important role through G protein coupled receptors and pathways. But this is important for us to know because this is the mechanism by which people think we can target pro-inflammatory processes. So cannabinoids have been looked at in various ways to try to see how we can modulate the endocannabinoid system to promote beneficial effects on virtually every organ system. We know as well there's a lot of information in the context of HIV, both in vitro, in vivo, and in human observational studies suggesting that cannabinoids can reduce inflammation in many different contexts. We did do a clinical trial to examine this because, as I said, most of the data so far are based on observational studies in humans. And we did have 10 people, and we believe we saw a few trends, but of course with 10 people it's a bit hard to draw too many conclusions. So this raised the question about how are cannabinoids, or cannabis, which we know a lot of our patients use, what does this do to an important system, the endocannabinoid system in the body, body and inflammaging. So Dr. DiMarzo is a Canada Research Chair on the microbiome and the endocannabinoid and with Dr. Janabian, one of my co-investigators, we decided to look at this in various cohorts of people living with HIV, and today we're going to present the results from the CHAC study. So the reason, of course, this could be important, the endocannabinoid system in HIV, is that we know that this system participates in pretty much all peripheral aspects of glucose and lipid metabolism. So this could be possibly a pathway we can attempt to target at some point to interfere with these harmful processes. We know also the endocannabinoid system is widely expressed on, the heart contains cannabinoid receptors, the smooth muscle cells, fibroblasts, and as we said already, many numerous immune cells, including macrophages and monocytes and cells which play roles in atherosclerosis. And there are, studies which have been done in HIV-negative person which show some associations with coronary artery disease and the endocannabinoid system. And there is a paper which came out as well which showed changes in the endocannabinoid system as a function of frequency of cannabis use in people with and without HIV. So if we look at endocannabinoid plasma levels, these have been shown in some studies to be potential biomarkers, as levels have been shown to go either up or down in important processes like lipid metabolism, obesity, and so forth. So class 1, I'll refer to, this consists of AEA and things like anandamide. Class 2 are things like 2-AG. This is the CHACS cohort, which is the cohort we used, and it's a prospective cohort including over 1,000 people aged over 40 or having HIV for at least 15 years in addition to negative controls. And these patients undergo cardiovascular imaging. So the coronary angiogram is done, and we can look at the size of the extent of the plaque. And this is led by Dr. Durand and Dr. Tremblay of the CHUM, as well as with Dr. Chartrand-Lefebvre of radiology. So we took the patients who had the most data available, as well as those who had stool specimens available, because we're also correlating these with microbiome results. So using liquid chromatography, plasma endocannabinoid lipid mediators were quantified. And then on a subset of those, we did Luminex and ELISA to look at soluble inflammatory markers. So in people with HIV, we found they had lower levels of class 1 endocannabinoid mediators compared to HIV-negative controls. People with atherosclerosis had lower levels of some of these endocannabinoids too, including DHEA, than people without coronary artery disease. With regards to class 2, people with HIV had higher levels of certain endocannabinoids than HIV-negative controls, and people with coronary artery disease had higher levels of some of these than people without coronary artery disease. We did not see much difference between groups in terms of the polyunsaturated fatty acids. And in terms of inflammatory markers, people with HIV and this subclinical coronary artery disease also had higher levels of interferon gamma than those without coronary artery disease, but we did not see differences in the groups for the other mediators we looked at, including IL-1 beta, IL-10, IP-10, and so forth. And people with HIV also had lower inflammatory levels and markers of gut damage than people without HIV. And those with subclinical coronary artery disease also had higher levels of intestinal fatty acid binding protein than those without coronary artery disease. And that's known to be a marker of also gut translocation. We did some correlations to look at mediators and coronary artery disease parameters. We found a negative correlation between class 1 and class 2 mediators. Class 1 and the polyunsaturated fatty acids positively correlated with total cholesterol. Class 2 positively correlated with triglycerides. In terms of cytokines and soluble inflammatory markers, IL-6 correlated with class 1 in polyunsaturated fatty acids, but it correlated negatively with class 2 mediators. And in terms of inflammation, we also saw some negative correlations with the first class mediators. So in conclusion, HIV and inflammatory status are associated with disturbances in plasma endocannabinoid mediators. The association of second class and first class with triglycerides and total cholesterol levels suggests a link between endocannabinoids and dietary fat in people with subclinical coronary artery disease. And the opposites associations observed with class 1 versus class 2 endocannabinoids may be predictive of subclinical coronary artery disease in people with HIV. So I'd like to acknowledge all the people, the large number of people, including Ralph Mubamba Boassa and Dr. Janabi and Dr. DiMarzo and Suzanne Samareni and of course, Dr. Durand, Dr. Tremblay, and all the participants who contributed to this large work.
Yeah.